I brought this topic up because I'm seeing a lot of rumblings amongst the research that I'm doing that statins could have the potential to have some kind of anti-cancer benefit.
They were also mentioning how it could help to inhibit the activation of EGFR on the outside of some of these cancer cells, which in these cases are mutated, so they're constantly on and they're sending signals to the cell to grow and grow and grow. But if statins are coming in and they're blocking that signal, they're not allowing EGFR to be phosphorylated, or they're not allowing it to dimerize, which is what's needed for it to become active, then that's going to help to slow that process down.
Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer.
Hi, everyone, and welcome to Cracking Cancer. Today, Samantha and I will be doing this solo, and we'll be talking about a very interesting topic on cancer and statins. So I'm going to pass it off to Samantha for a quick intro.
Hey everyone, Samantha Murrell, patient advocate. I have stage 4 lung cancer with a HER2 mutation. And I brought this topic up because I'm seeing a lot of rumblings amongst the research that I'm doing that statins could have the potential to have some kind of anti-cancer benefit. Obviously, it's never going to do the whole lifting on its own, but the question is, could a statin complement your existing therapy to benefit you and live longer potentially, or have a better effect on your therapy?
And for those who don't know what a statin are, they are actually the most prescribed medicine in the world. So a lot of people are taking these medications in order to help lower their cholesterol. And typically it's targeting a very specific cholesterol known as LDL cholesterol, which gets this name as bad cholesterol. And if you're listening, I'm putting that in quotes because it does have purposes in our bodies. However, the way that a statin works is that it actually prevents your body from making our own cholesterol. And you can get cholesterol in 2 different ways. So we're going to jump into a very quick nutrition lesson here before we jump into the oncology part. But cholesterol can be you can get it from your diet. So that's from animal products that you consume. And oftentimes a lot of people don't know that this is only coming from animal products. So you're only getting it if you're eating some type of meat, or you're eating like dairy or eggs. So if you're eating plants, that's not providing you cholesterol because they don't make cholesterol. And then the other way that you can increase your cholesterol is just within your own body. So we make cholesterol ourselves. There is a specific process within our bodies where we take a certain molecule called HMG-CoA, and then it gets turned into another molecule called Mevalonate, and then that's going to be turned into cholesterol. So some individuals are actually at a predisposed risk of having high cholesterol because they have more of these enzymes present that actually turn HMG-CoA into mevalonate. And one analogy that I like to think of is like you're taking sand and you're making glass. In the middle, you need fire, right, in order to do that. So in our bodies, we require an enzyme that's called HMG-CoA reductase. So if individuals have more of that reductase available, they're going to be putting more of that HMG-CoA into mevalonate and eventually into cholesterol. So that's how some individuals are just naturally at a predisposed risk of having higher cholesterol, even if they are not consuming additional cholesterol from their diets. And then what Samantha was just saying, there is a lipid that's made called isoprenoids, and these are actually used for some processes in other downstream proteins that need them in order to bind to cell receptors. And we're going to talk about that when we get into the cancer part, because those are actually really important. But before we jump into that part, I also just want to highlight that there are other cholesterol-lowering medications. So we're really just focusing today on statins and that mechanism I talked about. But it will be interesting to know if we dive into research, or if more research comes out in this topic, if it's actually the reduction of overall cholesterol, or if it's the specific mechanism of action of statins. Because if you're taking a different cholesterol lowering medication, there are ones that help to prevent absorption of cholesterol, such as blocking a specific transporter in your intestines. So that's going to help decrease cholesterol that you're consuming. And then there's also another protein within our bodies that's made that actually is blocking transporters within the liver that are supposed to be decreasing our LDL cholesterol. You may have heard of that, called PCSK9. So I'll just pass it off to Samantha now, just as we have that brief overview of LDL, just to hear about what's going on kind of in this research setting or in the community that's looking into this research and is seeing, okay, people who are taking these statins, and are they having a decreased risk of cancer? And then kind of what are they talking about?
Yeah, it's kind of like the whole GLP-1 discussion, right? We're seeing data around GLP-1s and potentially people having better outcomes when they're on a GLP-1 plus their cancer treatment. And the big question is it because they lost weight, or is it some mechanism to do with the GLP-1? And it's a similar situation here, right? Is it the fact that you are lowering someone's cholesterol for the better so they are healthier, or is there an underlying mechanism at play? I've been very curious about statins, in particular, the types that you mentioned. What were they again?
So there is the statins that are lipophilic. And
lipophilic, that's right.
Yeah, and that's a great distinction that you mentioned, because lipophilic statins are more cell permeable. So they are essentially able to enter a variety of different cells. But then there are ones that are hydrophilic, and those were designed to be more targeted for the liver to help to avoid any off-target effects. So they're really specific for hepatic tissues, like where they're going to exert the most effect.
Yeah. And essentially what I'm seeing out in the world, and whether this is an accurate statement or not is yet to be seen, is that a lot of individuals I feel that are going through cancer and are actually on a lot more medicines because of other ailments that they have, whether it be because they are overweight, whether it be because they have cholesterol, whether it be because they have high blood pressure. I'm seeing that all of these medicines seem to have some research of a potential off-label play on, could it also be cutting off some other pathways that your cancer is trying to signal on? And I kind of laugh at it in the fact that a lot of us, a lot of my friends at least, who have cancer, stage 4 cancer, have notoriously never been on any medicine. like our whole lives, it was like a pride thing that, we never took, like I wouldn't even take an aspirin when I, had a headache or a Tylenol. And I'm beginning to realize that maybe that is not necessarily the best play, and that there are things going on here potentially. For me personally, my family history notoriously has very high blood pressure and very high cholesterol. It's very much genetic. My grandmother and mother are both vegetarians, ironically, given that you mentioned it comes from animal proteins, and their cholesterol and blood pressure is absolutely through the roof. So very much genetic there, and not much they can do. And I remember when my mom was offered statins, she was freaking out about it, and she was like, "Oh no, this is terrible. Statins are bad." And statins recently, I think, have got a really, really bad rap. And I'm not quite sure why. I think there's just certain influences, we won't go into it, who talk really bad about statins and say that there are other ways of going about it. And so there was a lot of fear for her to start them. So I started really digging into it. And this is what led me down to the rabbit hole of, actually, there could be some other mechanisms here unrelated to the actual cholesterol component that could potentially turn off some signaling in certain cancers. Not saying it's every single cancer out there, because again, every cancer is different. But is there something to be said? Just like the GLP-1 discussion, right? I'm going to try and do another podcast with you on beta blockers. So like there's a lot of these drugs that are really cutting off signalings in ways that I believe that potentially cells might thrive off of in order to grow. And so the question is, are they helping or not? Or is it just the fact that these people are getting healthier?
And it's unfortunate too that you mentioned certain individuals who are putting a bad rep on these medications, because I'm not 100% certain on this, but I know that since statins have been around for so long, they have a ton of research, maybe the most research on them done for a prescription medication. And they help individuals who do have that genetic predisposition where your bodies are just making too much cholesterol. There's nothing you can do diet-wise that's going to help to reduce it. So if they're trying to sell this cleanse or this product or something, it's not going to work for those individuals who have already tried everything. And actually, a statin is one of the best ways that you can do to reduce that cholesterol. So it's unfortunate that those things happen, but I hope that individuals who listen to this, they listen to other individuals who are in the scientific and medical communities and patient advocacy groups, that there's research behind the medications that you're taking, and to trust your care team and look into that before just blindly accepting the advice of an influencer who may be trying to sell you a product.
Yeah. I'm realizing actual prescription medicines actually potentially have more anti-cancer benefit than the snake oil salesman selling whatever vitamin, right? Which I find kind of ironic, really, in the grand scheme of things, that all of these wellness influencers bash all of these prescription drugs when I don't think they actually truly realize what mechanisms they're working off and the potential benefits they could provide, far more than a supplement that might overdose your liver and cause problems. So
Absolutely. Yeah. And I think that that's a great segue for us to look into this mechanism of why statins might potentially have some anti-cancer effect. So as we talked about in the beginning, as HMG-CoA is being metabolized in the liver, it's going to produce downstream eventually cholesterol, but it's also going to produce another lipid called isoprenoids. And these are lipids that are produced from the same pathway. So if you're blocking that pathway, we're going to see those reduced as well, right? So cholesterol gets reduced and these isoprenoids get reduced. And they're these specific lipids that get attached to proteins and help proteins attach to cell membranes. And then those can become active in certain locations. And some of the proteins that they can attach to are actually things that you may have heard related to cancer. So I'll see if you've heard of these, Samantha. I'm sure the answer is yes, but RAS and Rho.
I haven't heard of those.
You have not? Okay.
No.
They are they're essentially like two switches within the cell. So they're these things called master regulators, and they help to turn on other proteins. So it's almost like this cascade of like dominoes, right? One gets turned on, then another. And they really help to tell the cell to grow and also involved in some movement processes as well. So these critical proteins need to have that extra little lipid tail attached to them, which comes from that same pathway that the statins block. So if those proteins are mutated in cancers, and we do have a lot of RAS mutations, so maybe people have heard of RAS mutations affecting someone's cancer, that's because that protein is essentially on too much. The switch that's supposed to be able to be flicked on and off is stuck in the on position, right? So it's constantly telling that cell, like, let's keep growing. And then eventually you get cancer and a tumor. So if we're decreasing the ability of that protein to have that extra lipid attached to it, helping it to become activated, could that potentially decrease the growth of that cell, that cancer cell? I don't see why not. I mean, the mechanism there seems to make sense. I think it's possible for the body to still produce these isoprenoids. So it's not like this is the only pathway, and blocking it isn't going to completely shut everything off, just like blocking it isn't going to completely shut off cholesterol production, right? We're still going to make some. But maybe that helps to slow it down. So maybe that's where we begin to see some effects in certain types of cancers, like individuals who have a very specific mutation and a specific biomarker that they've detected that this mutation affects them, and why they could get benefits from not only their treatment that they're getting for their cancer, but also these additional medications that they're taking that benefit their overall health. I'm not sure if that whole process made sense. So let me know, Samantha, what needs clarity.
So this specific mutation that you're talking about, so you're saying that for example, HER2, I did some research that HER2 and EGFR works off a specific pathway related to cholesterol. And I apologize, I don't know the exact thing off the top of my head. It says here that the HER2 signaling pathway and cholesterol metabolism interact closely together, where cholesterol dynamics regulate HER2 membrane localization and cell survival. And I believe I also found that for EGFR as well. And so I was curious if you found anything like that, or I'm just kind of pulling, or Google's maybe pulling that out of thin air.
Yeah, I think that is definitely possible with the RAS mutation, because it looks like the RAS mutation is affecting these pathways that have a variety of different acronyms. So there's RAF, there's MEK, there's ERK. And I know for sure that MEK and ERK, along with mTOR, which isn't mentioned here as being affected by RAS, but those are all pathways that are affected. Okay. And I know that all those pathways are affected with the HER2 mutation.
Gotcha. Okay.
So
gotcha.
I imagine that it's coming in at some angle, and I think that they're getting hit from a variety of different points, right? So it's not just this linear pathway. I think that's why we can have so many different mutations that all end up having the same downstream effect. But I can see where these HER2 mutations are aligned with this same, with maybe showing some benefit, because at the end, with this MEK and ERK also being affected that help the cell to grow and divide, those are targets of RAS. And then I know that those are also targets with that HER2 mutation.
Gotcha.
So I could see that there could be benefits there if someone does have that specific mutation. So I think, it goes along with your point that you were mentioning, how this could be specific for certain cancer types. Like, we're not at all saying that this research is the Hail Mary, right? Of like for every cancer type, like, which I know we cover every episode that we're on, we're either debunking information or we're covering research topics, that every cancer is so unique that you never know what those downstream pathways are that are going to be affected. But in this case, those specific ones could show benefit here.
Yep. Yeah, I just wanted to make sure we pulled that piece apart, because I wasn't familiar with the RAS thing, and I'm not sure people listening would necessarily have any idea what that means. And they'll be like, oh, that's not me. And then they'll move on, right? But I just kind of wanted to make it clear that it seems like HER2 and EGFR, it seems to be to less degree, but still is somehow interplays with this cholesterol dynamic, which is kind of super interesting to me, especially for breast cancer individuals who are expressing HER2, given that cholesterol mechanism, I think is super interesting.
Now, when you were seeing this information and kind of diving into it, was it a lot of anecdotal, like individuals just talking about their experiences and comparing their situations to others? Or did you see any studies where like people were maybe promoting some type of benefit? Because I have two and they're both sides, but I just wanted to know like kind of what folks might have been talking about before we dive into like picking those apart.
Yeah, so I'll be really honest. I haven't seen anyone talking about this. I haven't seen anyone talking about this online. I randomly put it out into our young lung cancer advocacy space to see who was on statins, and a bunch of people responded and told me. Then come to find out that a lot of people who have the ALK fusion are on statins because the TKIs give them high cholesterol. Around 90% of individuals with ALK fusions in lung cancer are on a cholesterol statin. And so I found that really interesting as well, given that the survival rate of an individual with ALK lung cancer in particular is exponentially longer than other individuals. But I will say, now learning about the two different types of statins, the lipophilic, did I say that right?
Yep.
And the other ones metabolized in the liver, I do believe that a lot of people are actually on the ones metabolized by the liver. So maybe that's not a correlation there, if we're concentrating on the other ones.
Yeah. It would also be interesting to know eventually, if this got some traction, if there's individuals who are taking a different type of cholesterol lowering medication that we were talking about in the beginning, how there's these different buckets. And I know we're only talking about statins and their relation today, but I just want to keep posing that out there in case people do have information like on those different types of medications that either block absorption in our gut. Does that show benefit? Or is there something related to us preventing the protein that's also used to kind of inhibit the receptors that are supposed to be absorbing our cholesterol, but they're blocked? And then it would give a little bit more clarity on this is related to the enzyme itself and the downstream processes that it's affecting, or if it's associated with cholesterol. And is cholesterol doing something? I know you and Kyle have had some good conversations in the past about like inflammation and how that can predispose someone to or create an environment that's ideal for cancer to try and to survive. So I don't know. It just leaves so many doors open and it makes me have so many questions. And I'm like, I want to do so many tests.
I know. And honestly, the biggest study I found after I kind of put it out there in the space to see if anyone was on them or not, I believe was done in 2020 by MD Anderson. I don't know if you pulled that one up or not. It was one of the authors was actually Dr. John Haymack, who is my one of my oncologists. He was an author on it, and they took a large pool of people and looked at the benefit of statins or not having a statin in addition to the cancer therapy. So I'd love to pick apart that study at some point because I didn't go down the rabbit hole too much, but it did intrigue me that MD Anderson was exploring this a few years ago.
Yeah, when we're looking at that specific study, and they're looking at individuals with the EGFR mutation, it was interesting because the proposed mechanism that they're highlighting in that study was that not only what we talked about already, which is kind of following the pathway of HMG-CoA being converted into cholesterol and its other lipid byproducts and how those influence growth pathways, they were also mentioning how it could help to inhibit the activation of EGFR on the outside of some of these cancer cells, which in these cases are mutated. So they're constantly on and they're sending signals to the cell to grow and grow and grow. But if statins are coming in and they're blocking that signal, they're not allowing EGFR to be phosphorylated, or they're not allowing it to dimerize, which is what's needed for it to become active, then that's going to help to slow that process down. So that was a really interesting, like, directly showcasing the mechanism of this use, along with targeted chemotherapy in the case that they were looking at both. It wasn't just individuals taking one medication, but how it can have some of these effects for a very specific type of cancer, or individuals who have that mutation, which aligns directly with what you were saying, how this could be beneficial for a certain subset of individuals. And so then there was another one on breast cancer, but this was more so just looking at overall survival. So not nearly as in depth, like trying to identify mechanisms or anything like that. And I want to look at it just to make sure I get the statistics right. But they were essentially examining statin use in individuals in 12 months after someone had a breast cancer diagnosis. And they observed a significant association between statin use and improved breast cancer specific survival. So they had individuals with stage 1 to stage 3 triple negative breast cancer who were taking a statin for a year. And it was associated, the statin use, the statin group, was associated with overall survival and breast cancer specific survival. Now, they weren't doing any type of intervention, right? So these were just individuals who were already taking a statin. They probably had other like lifestyle changes that was not accounted for in the study, but that was an interesting association just to see that they did have that increase in survival just by having something extra along with their treatment. And it kind of is aligned too with another study, a larger study that looked at a couple different types of cancer that I found. And this one was looking at prostate, lung, colorectal, and breast cancer. And they did see, they stated in here, we observed a trend towards lower rates of prostate, lung, colorectal, and breast cancer in cohort studies. And I think that that's also important because the terminology there, which we can talk about in just a second, is distinguishable for other types of studies. But then when they repeated this process, they said this is not observed in randomized clinical trials. So when they looked at the data where they gave some individuals the treatment, some did not, they didn't see that same decrease in risk. So that's also interesting right there, whether that's associated with the actual drug itself. Again, lifestyle changes, specific mutations, who knows? But those differences in how a study is designed can also play a big factor in how it's interpreted.
Yes, 1,000%. I also found it interesting related to the EGFR one that you mentioned later down in the article. It was the paper, sorry. It was saying how they did some research on people that had never had lung cancer, but they did have cardiovascular issues. And if they did go on a statin, it reduced their chance of getting lung cancer by 50%. And I found that super interesting because, like you said before, is there an inflammation component there that if you have cardiovascular disease, you're creating more inflammation and things are going on in the body that could be more of a perfect environment for cancer to develop versus you're on that statin, you're in better cardiovascular health, so to speak, with that statin. And so is that creating an environment that's a little bit more hostile for cancer to form? So it seems to be there is potential that a statin could benefit an individual who hasn't even had cancer to prevent them from having cancer, potentially. So it seems to be that there's some potential in people that have never had cancer, some potential with people with earlier stage cancer and preventing reoccurrence, and then some benefit potentially at a later stage cancer as well. And I feel like they're all correlated somehow, but it's just fully understanding it. And, I get really frustrated with these papers because I don't know if it's because they're trying to play safe or whatever, but usually the conclusions are, this data's great, but we need more research. So
Always.
maybe you can talk about that. Like, why is that a thing? Is it because authors don't want to kind of put out there such insane claims that could be an issue for them? Or why is that? Because it is really frustrating as someone that's trying to really dig into research and find out what potential things could benefit them. And there's always that disclaimer.
I agree. I know it's always like you're trying to figure out the best story as the researcher to tell. And at the end of the day, usually you come up with this story that matches the data or the data should be telling the story, actually, is a better way to say it. And then you do want to preface that this was only done in cell lines, this was only done in mice, or this has limited data sets, or this needs more research done. And I do think it's a way to play safe because what one researcher does, of course, in order to have good rigor and reproducibility, you want that to be able to be reproduced by another research lab, independent of what you've done, using similar techniques, and they also see similar results. But that's not always the case. There can be, especially with this, if we're talking about a specific mutation that maybe does show a benefit with a statin, but in another case it doesn't. If someone is testing this on a subset of individuals that do have that mutation and they see great, and then they're testing it on a subset of individuals that don't have that mutation, another lab might say that data is incorrect and that paper needs to be retracted or something. And maybe there's this fear that we don't want that to happen to the hard work that was put into the paper. So it's almost like putting these safety nets to say, like, this is the confound of how this study was designed. This is exactly what the data tells us. We're interpreting it this way. So you're kind of going outside that circle a little bit. But to reel you back in at the end of these papers, they always say, but just as a reminder, our data shows X, Y, and Z. If we want to find out more, we need to either, expand population size. We need to test more drugs. We need to develop a new inhibitor, whatever it may be. And then, you have that disclaimer, which is frustrating when you are trying to synthesize it. You're trying to what is the main takeaway?
You start reading all the stuff, you get really excited, and then it'll be like, and then you're like, ugh. But I think an important topic for us to cover too is drug interactions. So, adding, when you talk to your doctor about adding another drug because of XYZ reason, I think it's really important to consider drug interactions. That's why pharmacists exist, right? And I was doing some really interesting research where, thinking like, oh, I can just take any statin, right? And I actually come to find out through my research that there's literally only one lipophilic statin that I can take that does not, and when I say interact with the drug I'm on, it doesn't inhibit the efficacy of the drug I'm on, but it actually amplifies the side effects of the statin. Which I found super, super interesting. So some statins side effects can be related to muscles, joint pain, things like that. And apparently some drugs that you can take can amplify that very toxically. So it's almost like you're consuming 3 times, 4 times the dose when you're actually not, due to the absorption differentiation, which I found fascinating, but also very scary that, probably not many people knew that fact when I was talking to my doctors about this. And while, of course, it would have been run through the pharmacist before it was prescribed to me, I just want to kind of put it out there that it is important to research that piece, because the last thing you want is severe joint pain or getting toxicity from a statin.
Yeah, no, absolutely. That's such a critical point to bring up, especially because all statins too do come with a certain dose. So if it's amplifying that's not good. But that's also why so many people are on statins, is because you can be prescribed something that's really low, right? Like it could be a very low dose statin just to offset a little bit of the cholesterol that your body's making. But if you have a very severe genetic mutation where you are making way too much cholesterol, they can lift that dose up and you can get a high dose cholesterol. And I have some friends who have been on those to help to really lower that cholesterol down. And that would be something that if you're prescribed a cholesterol medication as somebody who doesn't have that genetic mutation, and you think, oh, they're all just made the same, that's not the case. And the dosage of those different medications is also going to be different in order to either inhibit more or inhibit less of that enzyme to make cholesterol. So I think that's a critical point for people to just be aware of, not only with statins, but for any medications as well. Especially like as we talk about compounding different types of medications with your overall treatment plan, checking in with your doctor. I think like when we did the GLP-1 episode, it was so great when you had mentioned that like you went over this with your doctor, like you came up with a plan, for your team, but it wasn't just like, oh, I'm going to just take someone else's medication because it's available to me. Because I saw something online or I read something. Right. It was really looking into making sure that didn't have those interactions, which is
those
like
interactions
the best thing
so
to do.
Important. Yeah, and what I will add too is you mentioned about the mutation aspect. So what I found out is, so on 23andMe, if you have a 23andMe data, it actually tells you as part of 23andMe now, I think it's the extra health plus one, but it tells you how you absorb statins and if you have a statin absorption issue. And apparently there's like 3 levels. There's one level where you should absolutely never take a statin. And essentially it's super, super toxic to you. You'll get severe muscle aches, like it's just a no-go. There's like a middle ground one, which is like you're okay on like very, very low doses. And then there's obviously you're fine. Interestingly enough, I'm the middle one.
Okay.
So that was super helpful for me to know. And not many people would know that unless they checked their, genome, so to speak. But so I now know that when I ask for it, that I need an exceptionally low dose. And if I do get side effects, it's likely because of that potential reason, and that I probably should not take them. So I feel it was very interesting to me that 23andMe had that piece on statins in particular. And I'm hoping in the future they'll do more of that, or we'll just know more about that, like in terms of what our bodies individually absorb, can't absorb, things like that, because I think it's absolutely fascinating.
And I think that just shows how much research has been done on statins too. Like the fact that there's a specific statin page associated with this genetic testing. Those aren't just, those don't happen for many medications, I imagine. But when you have a medication that has been studied extensively, it can show up there. So for those individuals who have heard that, statins have this bad rep, again, listen how much research has really been done on them.
Yeah, it's called the SLC01B1 gene effects on statins.
I think that's a transporter.
The transporter function, yeah. So normally this protein helps clear statins out of your blood and into the liver where they are processed. If you have an abnormality in that, they are not cleared as quickly. So that's when you get the heavy side effects. Ironically, I also have that with caffeine. So I have a genetic variant where I absorb caffeine, very, very, very slowly.
Okay.
And so it makes sense because I have like 2 sips of coffee and I'm awake for hours and I'm jittery. So like it makes sense. But it's just fascinating to me how you can find this stuff up, find this stuff out about your body and how it functions, and it kind of just all makes sense.
I feel like it's just evolving us more and more for personalized medicine because of how much we know, whether it's related to a cancer that you're getting a precise therapy for, or whether it's for a different health ailment that you want to make sure you're getting medication that is most beneficial to the way your body is going to metabolize and process that medication. As these advancements come out, as we learn more about genetics, metabolism, biochemistry, etc., that's what allows individuals to get these medications that can be beneficial for them, avoid as many side effects as possible, and then hopefully have, prolonged either like minimizing the health implications of whatever that health ailment is for them specifically. I think it's just, I don't know, it's fascinating. We could do something on pharmacogenomics or, anytime, because that would it would be awesome to have a geneticist on and just talk about that.
Yep, absolutely.
There's so much repurposing of drugs that we've talked about in previous episodes, which is so cool. And once they're approved for one thing, I think it opens the door for them to be looked at in other instances, not as a standalone treatment, of course, not saying that, but like with the idea of the diabetes medications like GLP-1s or metformin. And now they have been actually explored for cancer. And like now we're talking about this with statins too. So it's very exciting, I think, to know that there's still research going on. You almost think like once a medication is produced, it's marketed, you see commercials for it, like it's for that indication, and like the companies are already working on the next latest and greatest, which they do have innovation in their pipeline, of course, but then there's also studies that are looking at like, what else could this medication be used for? And we see that constantly with different indications coming out for already approved medications. So I like looking into this stuff.
Yep, I'm all for it, and I'm sure there'll be some people out there that would say, well, doctors aren't making any money off fenbendazole and ivermectin, which is why those ones aren't being used as off-label. But I digress. A $4 a month beta blocker or whatever, like, it is so cheap with the right insurance, so to speak, potentially, and it's like they could really have an impact. But I also think there's something to be said, for taking too much. And I don't know where that fine line is, and I haven't figured that out myself either. I do get scared sometimes or nervous of, is there a point where you add so much and use theoretical science that you're actually maybe causing so much pressure on the cancer that it gets really upset? I mean, I know it doesn't have feelings, but it gets so pissed off that you're shutting down all of these things that it wants to try and use, that it's going to just come back with a vengeance. So I don't know. There's a part of me that thinks that. I don't know if that's just all in my head. But I do think there's something to be said for, you don't want to be taking 50 vitamins and off-label drugs all at once. You really have to do your due diligence with your doctor, with the research, to find out a simple plan that works best for you and your cancer. Please don't start taking 50 things.
Beautifully said. Yeah. I can't think of a better way to wrap it up, because I think that's like just icing on the top of why we're covering these type of things on the podcast. Not to endorse it, not to tell individuals to go take it, but to just look into it, talk to your care team and see what works for you. And also to bring us what you find in the research too, because we want to know if there's information that you're hearing about something being repurposed or maybe having other anti-cancer effects alongside of the standard treatment of care that we could have a discussion on, and we can look into the mechanisms.
Absolutely.
So any last takeaways, Samantha?
No, I'm just looking forward to more conversations. Beta blockers, aspirin. I've got a list.
Awesome. Okay. Well, this has been Cracking Cancer. So we'll see you next time. And for more information, visit crackingcancer.org. Thanks, everyone.
Thank you.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.